filtrates, such as water, ions, and the small molecule are again reabsorbed, and these and the rest are excreted into urine. So those passed through the glomeruli, they may be reabsorbed. It's what this sentence said. But in the last one, they will be excreted into urine at the known concentration. So if the concentration goes beyond, then there is a problem. So we will see the normal range and the reference range about these substances that are excreted through the urine. So this excretion depends on the level of the blood, on the level in the blood of these substances. The compound whose excretion in the urine depend on the level in the blood are known as threshold substances. So I will show you the Renal threshold, how it is calculated, and what is that. At the normal or low plasma level, they are completely absorbed and they are excreted in the urine. So there are substances or compounds that are eliminated through the urine at low level. Actually, they should be at low level. If they are at high level, like high quantity, then there is a problem. It means that our kidney are not working properly, because they should. If they are working properly, then a certain concentration of substance will be eliminated. And if they are low and those substances are again appear in blood, then there is a problem. It's indicate that the kidney are not filtering or are not eliminating the waste as normal, in a normal condition. So the renal threshold of substance is the plasma level above which compound is excreted in urine. For example, the renal threshold of glucose is 180 milligrams per deciliter. This means that the glucose starts to appear in urine when the blood level is above this concentration of 180 milligrams per deciliter. If here you understand well, if I ask you, like you get results from the laboratory and they're indicating that the renal threshold of glucose is 200 milligrams per deciliter, what will you confirm? What does mean to you if the renal threshold of urine is greater glucose is greater than 200? It means maybe there is a problem, maybe diabetes. Yes?
Yes.
But remember, I taught you that you cannot confirm diabetes based on one test. So you will have to do other tests, like blood glucose, as we learned last time. So renal function tests intend first to identify renal dysfunction, of course, diagnosis renal diseases, to monitor the disease progress, to monitor the response to the drug, if our body is eliminating the drug, if the drug, how the drug is being eliminated from our body. So the renal function tests also play important role there. So These tests include glomerular function, test for tubular function, and urinalysis. So we will go one by one and see what are the tests for glomerular function. Actually, there are three main tests. One is the glomerular filtration rate. This is measured by clearance test. Another one is cystatin C. Another one is proteinuria. So this is to measure the glomerulus. As we know that the glomerulus, the role of a glomerular is for filtration for substance that has a high molecular weight. So if the, for example, albumin pass there, I told you that it indicates a problem. So the presence of protein in urea is called the proteinuria. So this may indicate that there is a problem in the filtration. So for glomerular filtration rate measured by clearance tests, we will focus on serum creatinine and the creatinine clearance, of course, and serum urea and the urea creatinine and the inulin clearance. So what is a creatinine? So creatinine, actually I told you that a creatinine, a urea, and the uric acid are the wastes, are metabolic waste. So creatinine is one of them. It's also waste produced by muscle activities. So this test measures blood level of creatinine, a byproduct of muscle energy metabolism. The production of creatinine depends on individual's muscle mass, which usually fluctuates every year. That's why the reference range are different because this will depend on the mass of the muscle. Like if the reference range for a man will differ from reference range for a baby because they don't have the same muscle mass. They don't have the same mass of their muscles. That is why the reference range will depend to the individuals. So, but the reference range, the average is 1.2 milligram per deciliter of muscle of athlete. Muscle of athlete is a normal function, where the same value in a small sedentary person with little muscles may indicate significant renal impairment. With normal kidney function, the amount of creatinine in the body remains relatively constant. So if your kidney are working properly, then the amount of creatinine will remain constant in both blood and the urine. But if there is your kidney are not working properly, and then the creatinine in the blood will be elevated, which indicates that your kidney are not working properly. Of course, that will indicate a problem, especially in glomeruli. So the creatinine also may be affected, but very little by liver, and the elevated blood creatinine is more sensitive indicator of impairment kidney function than both urea and nitrogen. Actually, this creatinine is the main one during testing the renal failure or glomerulus problem. So the creatinine is the main one. It's greater than blood urea and nitrogen. So the reference value of this, I told you that depends on the individuals. For example, for male is 0.7 to 1.4 milligram per deciliter. So for female is 0.6 to 1.3 milligram per deciliter, and for children is 0.4 to 1.2. So the creatinine level, if it is more than 1.5, and then it will indicate impairment on renal function. So these are the reference range that you will refer to know if there is a function or not. So if it is greater than this 1.5, then there is a problem. So if it is more than this one, then you may think there is a problem. But based on creatinine only, you cannot confirm. So you have to test other tests, other substances like urea, blood urea nitrogen, like that, so that you confirm that your patient has a renal problem, a renal function problem. Okay. So after urea, there is also blood urea. Sorry, after creatinine, there is also blood urea nitrogen. So this blood urea nitrogen band is the amount of nitrogen from urea containing in the blood. So we know that urea contains 2 nitrogen atoms, which each one of these 2 nitrogen atoms have 14 atomic mass, which means that the 2 will make 28 atomic weight. So the combination of two nitrogen atoms. So the total molecular weight or the total molecular mass of the urea is 60. So this means that the contribution of nitrogen in the molecular mass of the urea is 28. So that is 28 under 60. That is equal to 0.47. So therefore, the serum urea level can be converted into band by multiplying to the serum concentration of urea multiplying by 0.47. So I think you understand this, because if you know that the contribution of nitrogen in the total mass of the urea is 28, and you know that the total mass of the molecular mass of the urea is 60, then you take 28 divided by 6, and you get 0.47. So this is the contribution of blood urea nitrogen in urea. So if you have, for example, 25 microgram per deciliter of urea, then they ask you, or we ask you, what is to calculate blood urea nitrogen? So it will be, you just multiply by 0.47. So I hope you understand this formula, because I may ask you to calculate blood urea nitrogen. So the reference interval for blood urea nitrogen also will differ. In adults is from 6 to 20 microgram per deciliter. And of course, you know that the decrease, it may indicate something. So the decrease of band, it's indicate liver disease, where the increase of this band may indicate renal disease. But as I said, you cannot confirm the renal diseases or renal problem with only one test. So if you get results that indicate that band is greater than 20 microgram per deciliter, then you may think there is a problem, but you cannot confirm with that one. To confirm, you need to also to test the creatinine. So this combination of band is the blood urea nitrogen with the creatinine, will give you a good indicator. So it will give you a good result. So it is a good indicator of kidney function failure. So it's of kidney problem. Let's say that. I told you that creatinine is a good indicator of kidney function. I told you that it's better than the urea. You know why? It's because urea is very sensitive. For example, in the case of mild dehydration, the urea will be affected. In the case of high protein diet, urea will be upregulated. Means that the urea will be high. In the case of increased metabolism, urea will be high. In the case of muscle waste in starvation, the urea level will also increase. So all those factors may affect the increase of the urea. So that is why we say that the creatinine is better than urea, because urea is somehow sensitive to many factors. So the terms elevated concentration of urea in the blood is called uremia or azotemia. It is called azotemia because of that nitrogen. So the cause of urea plasma elevation may be prerenal, renal, and post-renal. So it is prerenal when in the case of hyperperfusion. So it is renal in the case of tubular necrosis if there is tubular problem, and post-renal in case of obstruction of urinary flow. You know the urinary flow. So in case of the obstruction of those flow, then we can say that it's prerenal. So the cause of elevation of this urea in plasma may be from all the three sources. So the parallel determination of urea and the creatinine is performed to determine between prerenal and the post-renal. Of course, if in prerenal azotemia lead to increase urea, while creatinine value remain at a reference range. While in the post-renal azotemia, both urea and creatinine level will rise. So you have also to calculate the blood urea nitrogen and the creatinine ratio as they are an indicator of the renal failure. So the level is this one you're seeing here, and high blood urea nitrogen to creatinine ratio occur with certain acute kidney failure. The blockage in the urinary tract, such as kidney stone, can cause high blood urea nitrogen ratio. So this ratio, if it is high, then there is a problem of blockage of urinary tract. So this also may be caused by bleeding, by diet low in protein, and severe muscle injury. So the glomerular filtration rate. So glomerular filtration rate is decreased when the blood pressure is below 70 micrometer, this 70. And when there is obstruction of renal flow, glomerular filtration rate increased by 50% in pregnancy. The reference range depends on the weight of the gender. For example, in individual weighting, glomerular filtration rate is from 120 to 125 liter per minute. So the clearance that are used for measuring this glomerular filtration rate are, of course, urea clearance, urea clearance, and creatinine clearance. So you may ask question, what is the clearance? clearance is a volume of plasma that would be completely cleared for a substance per minute. For example, the formula of urine volume divided by concentration of substance in plasma. So creatinine clearance is free filtered at the glomerulus and not reabsorbed nor metabolized by renal tube. The normal adult clearance is vary from 97 to 137 milliliter per minute. And when you correct the surface area, creatinine clearance value will become compared between male and female and children, which is about this one. So the decreased clearance, creatinine clearance is a very sensitive indicator of glomerular filtration rate. So there is also urea clearance. So urea clearance is calculated by taking the urea concentration. So you take urine, you measure the concentration of urea, and you multiply the urine volume per minute. So the quantity of urine per minute, and then you measure the concentration of urea in the serum. So this means that if you want to calculate the urea clearance, you measure urine concentration in the urine, of urea in the urine, you measure the concentration of urea in the serum, and then you measure the urine output within 1 minute. And then you take urine urea concentration times urine volume per minute, and you divide by urea concentration in serum, and then you get urea clearance. So the normal value for urea clearance is 75 milliliter per minute. So then the urea below 60% is considered impaired, and the urea is normally absorbed from tubule, and therefore tubular function is also affected by urea clearance. So inulin is also another indicator of this glomerular filtration rate. So inulin is a polysaccharide. It's a kind of polysaccharide which is made up by fructose. This also, in case it will indicate the problem of this glomerular filtration rate. So a below normal clearance shows that impaired glomerular function, and normal inulin clearance is between the normal value is between 100 to 130 milliliter per minute. So also calculation, we have to measure the concentration of this inulin in urine, and then you measure the volume output, and then you measure the concentration in the serum. So, and then you apply the formula. So I gave you the formula here. So the presence of protein in the urine is called proteinuria, as I told you. So the three main form of protein or of proteinuria are glomerular proteinuria, overflow proteinuria, and tubular proteinuria. So glomerular proteinuria, is for filtration. So if you hear a word glomerular, you just have to think about filtration. So the loss of the protein in urine due to increased filtration load, it is indicate the glomerular proteinuria. So, and then if you have overflow, it means that there is increase of concentration. And then if here tubular, tubular, it means reabsorption. So the loss of protein in the urine due to decrease reabsorption capacity of urine, it's what you call tubular proteinuria. So no protein extraction is less than 150 milligram per day. The protein extracted are mostly made by albumin, which is 50 to 6%, and some small protein, other protein. So the protein above these 300 microgram per day is generally pathological, so it's a problem. Per day, gram per day. So if it is above that one, like for example, it is 300 milligram per day, then it will indicate a pathology. So the glomerular filtration of protein, the glomerular of kidney are not permeable substances such as of molecular weight. So the plasma substances are normal in the urine. So when the glomerular are damaged, so if there is a problem in the glomerular, then the more it will become more permeable, and then plasma protein will be high, and the protein may also appear in the urine. So the presence of albumin in the urine, it will indicate a problem because albumin is the biggest protein that we know. So the biggest plasma protein, of course. If this protein pass through the glomerulus and is eliminated in the urine, then it indicates a problem in filtration. There is a microalbuminuria. It's also carried in minimum albumin or albuminuria. This is the small quantity of albumin that may pass in urine. It is not indicating patient with overproteinuria. So our morning midstream fair. So microalbumin, it is early indication of nephropathy in a patient with diabetes mellitus or hypertension. So the presence at high quantity this microalbumin from above 300 microgram per day, it will indicate that there may be a problem of diabetes or there may be a problem of hypertension. So people with, so this means that people with diabetes or people with hypertension, these microalbuminuria should be screened. They should be screened for this microalbumin. So the other one that we will check for glomerular is cystatin C. This has a low molecular weight and is synthetic virtually in all organ of the body. It will be increased in blood flow and free filtration in glomerulus, in urine, and non-tubular secretion. This one is excellent marker for glomerular filtration rate. As the blood level, it doesn't not depend on extrinsic factors such as sex, age, and diet. So this is good because it will not depend to other environmental factors or other factors such as sex, age, and diet. So we finished with the glomerular, and then let's see what about tubular function. So for tubular function, to assess this tubular function, we have to measure the specific gravity in the urine, the concentration test, the aeration test, and the urinary acidification. Those are the main tests that I perform to assess the tubular function. So the specific gravity, of course, it's the measurement of urine density, which reflects the ability of the kidney to concentrate or to dilute urine relevant to the plasma from which is filtered. It measures the amount of substance dissolved in the urine. It indicates how well kidney are able to adjust the amount of water in the urine. So this indicates, of course, how kidney can adjust water in urine. I will give you an example how this is done. So the normal specific gravity is varied between 1.015 to 1.025. So the increased specific gravity, of course, it will indicate lower water intake, or in case of diabetes, or in case acute nephritis. The decrease of this specific gravity is in excessive water intake. So this, if the specific gravity is decreased, then it means that there is excessive water. There is a dilution. Or also there is chronic nephritis or diabetes insipidus, which means the water is eliminated at a high quantity from the body. So in these cases, the specific gravity of urine will be elevated. There is also for testing this tubular system, renal tubular system, in lab they may perform a concentration test. So the concentration test is the ability of the kidney to concentrate urine. To concentrate urine is a test tubular function that can carry out readily without minor inconvenience to patients. So how this test is done? This test, of course, because the concentration, it's require water deprivation for 14 hours for healthy individuals. So if for this test, you will ask your patient, do not take water for 14 hours. And then the specific gravity will be measured. If it is less than 1.02, then it will indicate normal concentration power, if it is less. But if specific gravity still is beyond 1.010, if it is less, here it is. If specific gravity is greater, is more than 1.05, it indicates that there is no problem. But if it is less than that one, then the condition is called Azotemia. Another test is dilution test. For the dilution test, also the patient will need to be fast. So the patient will not take anything to eat. So after the overnight, the bladder will be empty, completely empty, and the water will not be given from 1 ml, from 1 liter to 1 liter 0.2 ml. So then the specimen will be collected in next 4 hours. The patient emptying bladder completed on each occasion. Normally, the patient will excrete 700 milliliters of urine in 4 hours, and then at least one specimen will have specific gravity less than this one, 1.04. So the kidney which are severe dimension cannot excrete urine in lower specific gravity than this one, or more than the 400 milliliter in this time. So you know that in edema there is a high volume of water. So this test is not recommended for people with edema or renal failure, because this may affect the results. So urinalysis, there are many tests that are carried in the laboratory to assess the function of the urine system. Of course, for urinalysis, you check the color of the urine. So the dark color indicates the concentration of urine, the presence of the other pigment. You know that the urinary, there are pigments that may give color to the urine, like a urobilinogen. So urobilinogen is from degradation of hemoglobin. I think you know that. You know that when the hemoglobin is degraded, and then we give to bilirubin, and then to bilirubin will be conjugated. After conjugation, they may pass through the bile duct. One part will pass through and then it will be eliminated through urine and feces. In urine is urobilinogen, and feces is stercobilinogen. So those pigments, they are the one to give the color to the urine and to the feces. So you check the color. You check also the turbidity. So the turbidity may indicate infection. You know, there are many urine infections, for example, bacterial infection, like a Escherichia coli infection, a Klebsiella infection, like a Neisseria, gonorrhea infection. So you check in case of infection, then you can see turbidity in urine. So for urinalysis, first of all, you have to examine or to check the appearance of the urine. So this are called microscopically examination of the urine. It means you check the appearance of the urine. For checking the appearance of the urine, I told you that you have to check the color. The color may indicate the presence of the pigments. If the color is too high, it means that there may be a higher distribution of red blood cells, hemolysis. So the turbidity may indicate the infection. I gave you an example of Escherichia coli infection, Klebsiella infection, Neisseria gonorrhea, and the other infections. So if the turbidity is present, there's a problem. And you check the pH, and you also check the specific gravity. So after that, you also check there is also microscopic examination. So the urine is centrifuged, then the urine after centrifugation, the pellet is collected, and you analyze the pellet under microscope. So you may find crystals like a phosphate, urate, and the oxalate. You may also find the red blood cells. So the presence of red blood cells may indicate something, for example. Actually, the presence of red blood cells in the urine is called hematuria. So the possible cause of red blood cell in the urine, who can tell us the possible cause of red blood cell in the urine? Does someone tell us why white blood cell in the red blood cell in the urine?
Maybe urinary tract hemorrhage.
Hemorrhage, yes. If there is a hemorrhage in somewhere in the bladder. Why hemorrhage in the bladder?
Glomerular dysfunction.
Not glomerular dysfunction. Of course, the glomerular, but I told you that the glomerular dysfunction, the glomerular is for filtration. And now we are talking about hemorrhage, about bleeding in bladder. Why bleeding? There are many causes of bleeding in or urinary system. So just list 2 or 3.
Bacterial infection.
The bacteria. Trauma. Oh, yes, trauma. Okay. Another one.
Inflammation.
Inflammation. Which inflammation or which? Yeah, which inflammation? Okay. I think you studied microbiology or parasitology.
Yes.
Do you know schistosoma hematobium?
Yeah, we have seen it.
Yeah, schistosoma hematobium may cause bleeding in bladder because it lives there and it has a spine which may cause bleeding, bladder bleeding. That's one. Another one is cancer. Yes?
Yes.
Okay. So there are many. I'll just give you some examples. You may also see the white blood cell. The white blood cell, they are the one, they indicate what? The white blood cell in the urine?
Like infection?
Yes, infection. You
Even
are right.
inflammation.
And inflammation. So if there is an infection, then there will be the response of the white blood cell, the response of the immune cell, immune system. So the immune cell, like nitrogen, called the clonic. But if it is a trauma, for example, and then it is rapidly, it is called acute. So there are different signs and symptoms for that's in and the disorder of initial output, like low urine output, polyuria and urea and glomerular. This depends on the urine output. There is this also alteration in urine composition. I told you about hematuria, the presence of red blood cell in the urine, and the proteinuria, the presence of protein. Other indication of urine filtration is pain and the edema. Edema, you know, the water this can be accumulated somewhere. It means that your nephron is not able to maintain the sodium, water and sodium balance. It means that where sodium goes, the water will flow. So they have edema. So in case of nephrotic problem, or in case of renal failure, this this edema will also be considered as an. So acute renal failure this occurs during severe illness. So it's acute because it's severe actually. It's very simple. And it's divided into 3 categories. So you may divide this pre-renal failure due to decrease of blood supply, and you may also categorize it as a renal, intrarenal due to increasing damage of kidney, and post-renal due to urinary tract obstruction. So as I was saying, this is divided into 3 categories. There is a pre-renal. Of course, the pre-renal, it is decreased in the blood supply, and this is the intrarenal. So there is interesting damage to kidneys, like glomerulars and the tubular system. And they also post-renal to urinary tract obstruction. So if it's obstruction somewhere, like a bladder or urea, like that. So acute pre-renal, because of renal circulation insufficient, and may be due to intravascular depression of this hemorrhage, plasma volume, reduce of pressure of the results of vascular dilation. If renal blood flow is restored within a few hours, the condition is reversible. For this one, the condition is reversible. So if the renal blood flow is restored, then and then the condition is reversible. But The longer it persists, the greater danger or damage increasing renal occur. So there may be a problem somewhere. Maybe there is an hemorrhage. If someone is losing blood, for example, if there is a hemorrhage somewhere, your arm, you lost, of course, you will lost blood. So the blood flow in the kidney will be reduced. But this one is reversible. As long as you stop the hemorrhage, then the blood flow will continue as normal. That's why it is restored. But if it persists, like persisting of this hemorrhage, then this will be danger, as it may cause intrinsic renal. They are not sufficiently supplied with the blood. So the acute renal failure is, let's see, that the injection of various poison. So in case of poison, in case of drug, in case of myoglobinuria. So myoglobinuria, actually myoglobin, they are pigments that are present in muscles. Like myoglobin, if you know, hemoglobin is in the blood. So myoglobin is in the muscles. So this myoglobinuria is the presence of myoglobin. So it's the presence of that pigment present in muscle in urine. This also will indicate that there is, because this protein has a high molecular weight, if it's there, then in the case there is a problem in filtration, intrarenal failure. So there are also bone-Jones proteinuria. Those are also proteins that may be present in urine in case of acute proteinuria. There is acute failure. So the urine output would be low, anuria or absent, or urea, the low output, or anuria, the absent. This may occur in post-renal failure. For example, obstruction of urinary tract. This causes usually, but not always. Clinical obviously may be due to the following. I told you the obstruction, the blockage of tubular lumina, the hemoglobin, myoglobin, and the very red or calcium. So this myoglobin, once this myoglobin or hemoglobin, all those proteins, they are, of course, even though they are pigments, they are proteins. Once they are accumulated, they are at a higher quantity or high amount of these proteins or these pigments may cause the blockage of tubular lumen. This also results in acute post-renal failure. So they may also cause, there is also extrarenal obstruction. This extrarenal obstruction may be caused by cancer. For example, in case of prostate cancer, it may obstruct the tubular system of the urinary tract system, like any other neoplastic cancer, urethra structure or prostate hypertrophy, if there is a increase for urethra, is a so the structure urine may be caused by, I told you, the cancers, these protein like hemoglobin and the myoglobin is present in muscles. So I give you an example of
hemoglobin, because you know that all of you know hemoglobin, that is a pigment which is present in red blood cells that's responsible for respiration and giving red color. So myoglobin also is the same as hemoglobin, but this myoglobin is in muscle. So all those pigment or protein, they may be accumulated and they cause the obstruction of those tracts. So or those or of those ducts and cancers, of course. So what causes chronic renal failure? Chronic renal failure may be caused by the infection, may be caused by drugs, by inflammation, by urinary tract obstruction, by severe urinary infections. I told you in case of bladder infection, in case of parasite infection, it may cause chronic bleeding. So in case of Escherichia infections, in the case of trichomonas infections, all those may cause chronic renal failure. In the case of hypertension, so those are examples of the pathology condition that may lead to chronic renal failure. Syndrome. Now, nephrotic syndrome. So it means that the large amount of protein are lost in urine. Proteinuria or edema due to the low albumin and the secondary hypoaldosteronism develop. So if high quantity of protein is passing through the glomerulus and is eliminated in the urine, then they may also have a problem because they be low protein in the blood, which means that they be low of albumin, and the of albumin is transport, so because the edema. Usually protein loss in urine is this one, 5 grams per day. So more than this filtered glomerulus, but most of catabolize in tubular, and therefore the loss from circulation by those that appear in urine. For the renal stones, so the renal stones or renal calcule means that there is presence of the stones in urine or crystals. So the crystals are formed when the solubility product of urine exceeded, and there are factors such as debris of bacteria which promote the crystals formation. So the debris of bacteria will make crystals formation. Such as I will show you the examples for crystals, like a phosphate, like a crystals of charcoal, iodine, all are also crystals. So the crystals may result from the action of bacteria, and it will be eliminated in urine. So other factors which may make stones in the urine is the dehydration. So people, for example, people who live in the condition, environment, migration, who work very hard without taking water, be hydrated, and this hydration form. And because high concentration, then crystals all formed. So this is good indication. That's why you should take at least water, at least some liters of water per day if you are working hard. Because if you keep work hard and you take water, the urine concentration will be high, and this creates stones there. That is why sometimes you need to take something containing water. So this stone may cause renal, of course, it may cause renal damage. So for this stone to be formed, of course, there are factors that will comes in. For example, high urinary concentration. As I told you that if you work hard and you don't drink water, if you live under certain condition or environment which may make your urine to be concentrated, then stones may appear. That's one. Another one is low urinary volume with normal renal function. This is also the same if you don't take water and if you have low volume of urine. Another one is that of a metabolic product formed by stone. The change in pH also is one of the indicators. So that is not written here is that it's the uric acid. Uric acid also act of the presence of this stone, but mainly in the bladder, and then it's the uric acid as well will appear in blood. So I think I will find notes for the uric acid, and it's a good indicator of that. So I will find for you the note for that. Okay. Someone have a question? Someone? Yes.
I'm asking about on the slide 7. Why
Yes.
do people with nephrotic syndrome are more likely to have also secondary hyperlipidemia? Why?
Hyper?
Why do people with patients with nephrotic syndrome are more likely to have secondary hyperlipidemia, also likely to have secondary hyperlipidemia?
Yes. The slide 7.
Yes.
Okay. Mhm. Yes, okay, yeah, I can see it. Yeah. Do you know the metabolism of lipid?
Yes.
Yes. So if this hyperlipidemia is of course, the high concentration of lipids in blood. So if there is a nephrotic syndrome, then the urine, it will not able to do the metabolism of the lipids. You know, I told you that urine, the kidney might participate also in the metabolism, like beta oxidation and the other metabolism. Lipids also, if there is impairment there, so the lipid metabolism will be impaired.
Okay. Yes.
Yeah. Okay. So if any other question, then we can close today's session by here.
You can also share us the notes.
You see? Notes?
I wonder we can have
Okay,
notes.
okay, I'll share you notes.
Yes.
I have a question.
Okay.
Excuse me, sir.
Yes.
I've got a question on the presentation, slide number 12.
Mm.
That was the causes of urea plasma elevations, mentioning being prerenal or post-renal. Would you mind clarifying more on these causes, like explaining more?
Renal, post-renal?
Post-renal and prerenal causes of urea plasma elevation.
Slide 14.
12.
Oh my God.
So I can see slide 12 is talking about, okay. So you want to know how hyperperfusion or tubular necrosis or obstruction. So you can come again to your question.
I just want you to clarify more, like what is prerenal and post-renal? How do they?
Oh, okay. I told you that prerenal is from the blood flow. That's prerenal. If the blood flow is not enough, and then it will cause a problem of urinary concentration. Okay. You know that the glomerulars, the blood flow will come and it will filtrate. So if the blood flow is not enough, then it is a prerenal problem. And then post-renal it is in the case of obstruction during urinary tracts. You know urinary tracts, they're like urethra. Okay. There some or the bladder or those urinary system there. Please mute your microphone. If there is an obstruction, then it's post-renal. For example, because it may depend from other factors like tumors. Okay, tumors in case of cancer, of course. Other factors like I told you about the proteins like hemoglobin or myoglobin or stones. Those may cause renal obstruction. So that's why it's called post-renal. Renal, it is in case of infection during the tubular. You know that the tubular, they are the one for the reabsorption, for the solution. So in case of inflammation there, or in case of other pathology, so that's why you call the renal acute. So that's why we call the renal phases. So the pre-renal is because of the factors that are not from kidney, for example. The other factors that do not depend the kidney, for example, depend the blood flow. That's why we call it pre-renal. And then the post-renal, it's mainly the obstruction. You understand?
Yeah, I got it.
Okay, good. Okay, class, then see you Friday. But
See
I
you.
think you have a, huh? I think you have a practice in afternoon. You have to go for lab practicals in afternoon. So they show you how to test the protein in urine. They will show you the crystals, I think. They will show you how to test the glucose in the blood, protein in blood, how to measure creatinine, how to measure urea, how to calculate blood nitrogen in urine. But that's one, you know, this is a simple formula, how we calculate blood and urine nitrogen. So link up with Jean Dodier. He will help you. And I hope you all have gloves for the lab. So, and make sure you all attend the lab practice. If you don't attend, then I will give you 0. So I will give the marks for lab attendance. If you don't attend, so the lab will not be online. Okay?
Yes.
So have fun, have a good day.
You too.